So we had to pivot a little bit on this panel. We were expecting Linda Russo to speak and give some of her professional sort of expertise on strategies for advocating in the healthcare setting. She's unfortunately actually in the hospital right now. So we are going to have more of a conversation here, similar to kind of what we just did, but I think both of you, we'll start with maybe just brief introductions in the story, but then I'm hoping that this is actually pretty interactive and you all can sort of help us with this session, what you guys have done in your own experiences of having to advocate, what recommendations you have for each other about what works, what doesn't, or your frustrations and challenges, and we can maybe have a little bit of a brainstorm about, strategies that we can all sort of take home with us to these settings where, people don't really listen to us and our expertise. So I'll start with Amy. You want to just a little bit about yourself and your journey?
So I'm Amy Junge. We have a 17-year-old daughter, Emma, who's affected by CACNA1A. It is inherited through my husband. So our other two children also have it, but they are not as affected. And once she started developing symptoms, it took us 8 years to get to a diagnosis. And so we had a lot of experience with many, many dozens of doctors. And so I've really just learned how to advocate for Emma, and hopefully that might be helpful here.
And I'm Allison. I have a almost 16-year-old Sammy, who you've probably seen rolling around. Perhaps you've talked to her about Taylor Swift and her upcoming 16th birthday party that will be Taylor Swift themed, and she's determined that she's going to send an invitation to Taylor Swift. We'll see what happens. I'm also, like Amy, I'm on the board of directors for the CACNA1A Foundation. I'm also a lawyer. And so I think one of the things for me is that advocating is a natural skill set for me. Like I think I was truly born to advocate and fight for what I want. But, and we can talk more about this as we get into the substance, I think I've had to learn that, that advocating in a healthcare setting is not the same as litigating at my job. And of course it's not, because there's so much more feeling involved, et cetera. But even the skills and the way to go about it, I think are very different, related, but different. And Sammy was, Deb's story about testing and stuff really hits home for us, because Sammy had lots of testing as a little bitty kid, and we did have just initially a microarray. So I thought we'd had genetic testing, and we actually had traveled from where we live in LA to Johns Hopkins, had a microarray there, didn't find anything, and then she was given an umbrella cerebral palsy diagnosis. So I'm also a huge advocate that there are definitely other kids, teenagers, adults out in the world with umbrella CP diagnoses, and others that probably it's CACNA1A. And so just getting our numbers up, I believe, is a big part of it. But that story also just really hit home for me. And I wish that I had known more to advocate earlier for the full exome.
Amy, do you want to talk a little bit about getting a diagnosis, or one of the anecdotes from having to advocate for Emma?
Sure. I actually wanted to can I ask questions to the audience?
Yeah.
How many, I loved Dr. Grossman's term suboptimal experience with medical providers. I was like, yes, and yes. So how many of you have had suboptimal experiences with medical providers? Almost everyone, probably. And I think that that's really important. When Emma was young and we were trying to her symptoms were not super severe then, and so we were trying to figure things out. We got a lot of, I think I approached it like the doctors are going to know the answer, and that was a mistake. I think everyone in here realizes the doctors don't have the answers. And if you don't have a child with a rare disease and you take them to their pediatrician, and she's our second, so I'd had regular pediatrician experiences, pediatricians that I really liked, and I think we're trying to do really great things for our kids. One of the things the doctor said is think horse, not zebra. His theory was it's not rare, nothing is rare. And when he said that, he meant it as reassuring, like, she's okay, it's fine, she will outgrow this. And in hindsight, it was actually really harmful because it didn't put us on the right path to look for answers in rare spaces. And while it's rare to have CACNA 1A, it's actually not that rare to have something rare in your lifetime. And so that's, even if it's not your child with CACNA 1A, like, that's a lesson I take into every doctor's appointment for all our kids, for myself. Like, that the doctors are as knowledgeable and well-meaning, but they do not have all the answers. The science is always evolving. They are only as trained as their last training, and they don't know, especially for CACNA 1A, once we figured that out. I'm the expert. Like, I know more about this disease than almost any doctor we see on a regular basis. And so, like, you are the expert, and you're the expert in your child. You are the expert in knowing, like, this isn't just an off day, there's something wrong, right? Like, that instinct in you is as valuable as any test that they're going to run or observation. And so I think that, like, for me, the biggest lesson was there are ways to do it so that they don't shut you down and that they will engage. And there are sometimes you need to find new doctors. Like, we went through a lot of doctors, and we now have a really great team. But if you aren't getting where you need to get, fire the doctor. Like, move on, because there is someone else who can help you and your child better.
Do you want to?
Sure. So just an example of when we've needed to advocate, okay. So it's interesting because I think one of the things I learned about advocating in a healthcare setting came actually when my mom had surgery. And so my parents are in St. Louis. We live in Los Angeles. My mom had she told us was going to be like a routine back surgery, we don't need to talk about whether she was telling the whole truth, but it was anything but routine. She wound up in the hospital for 4 months. She got an infection. She had to have multiple other surgeries. It was terrible. And my family doesn't know, they don't push back when doctors give information. My mom was like unconscious, and she's usually the one that handles everything. My dad didn't ask questions. And so I would talk to him on the phone and ask questions, and he was like, well, I don't know, I didn't ask that. And so I started flying out to St. Louis from LA, sometimes twice a week, depending on how my mom was doing, back and forth. Even though I had little kids and a full-time job, I was taking red eyes back and forth and working in my mom's hospital room, going back to my kids. And obviously I could not keep doing that. I told a group of friends, like, I can't keep doing this. I'm gonna die. And someone said, well, have you ever thought about hiring a healthcare advocate that can be there for your mom? And so I had never even heard that existed. And I thought, like, I'm a lawyer. I know how to fight for what I want, and I know how to advocate, and I'm going to keep doing it. But I ended up hiring someone and who just went to the hospital like 2 or 3 times a week and was someone else who I could ask questions besides my dad, who was not asking questions. And I learned a lot by watching her because how she interacted with the hospital system, et cetera. And it wasn't like I did as a litigator, because I think when we are fighting for our kids, there's so much angst and so much desperation. And I always say I try to advocate with grace, but sometimes we're just out of grace. But those moments when we're out of grace, we often don't get what we want, right? And so I watched her from this more like objective place, advocating for my mom, and she did very simple things. Like, my mom was really out of it, and you would not have believed that 3 months before that, my mom was like a vibrant woman who was flying back and forth to California to see her grandkids. And so she wasn't being treated like she was that woman or like she was going to be that woman again. And so the advocate was like, we are plastering pictures of your mom in California with your kids all over the walls. They need to see her as that person, not the person in the bed, so that it's just like this humanizing thing. So when Sammy had her big hemiplegic migraine, it was really clear to me that we were at UCLA, one of the best hospitals in the country, a teaching hospital, but not where her normal doctors are, because we go to Children's Hospital of Los Angeles. And so the doctors there didn't know her. They didn't know her baseline. And it was really clear to us that they kind of didn't believe us what her baseline was, because she was so far from her baseline. And so I really tried to remove the anger, because that wasn't going to get me where I needed to be, and instead humanize her to them. And so we had one group of doctors who came in with the residents and were asking questions about what she's normally like. And I said, we were just in Palm Springs last weekend. She was swimming. Like the day before all of this happened, everything was fine. Look, do you want to see a video? And they saw her swimming around a pool and talking. And so I think sometimes it's about humanizing, and also just, it's so hard, but you fire a doctor who's definitely not listening to you, but also I think sometimes it's like trying to remove some of the anger. And I always say, like, if you have a kid with a rare disease, and we've all been through so much, it's really easy to go through life, I say, with our fists up, right? Because we've watched our kid get hurt in all these different ways, but trying to approach it really objectively, but always asking questions, feeling like you at least left the room with all the information that person could give you, is probably the biggest thing. And it's okay to ask questions, and you should ask questions. And if you don't understand a word, ask what it means. Don't be ashamed of that. And I think that's like, even Lisa and I had this conversation, even in this room, we are, me less so than Lisa and Sunitha, but still I'm in conversations with scientists probably more than most people as part of the foundation. There were still words yesterday that I don't know the meaning to. There were words that Lisa still has to remind herself what they mean. So don't feel dumb asking questions, and when you get your answer, if you still don't understand it, don't feel dumb asking them to explain their answer.
Absolutely.
Yeah. Lynn's coming. So Linda Russo, who was supposed to speak today, she works for an organization called LEND, which is Leadership, Education, and Neurodevelopmental Disabilities, which is a part of the federal program in maternal and health. You're nodding. Is it?
If you want me to jump up there, I'm also
Sure.
Yeah, please do.
Sure. Let's do that, because I'm a LEND fellow, and so I went through the LEND program.
There's a chair up here, Lisa, if you want to join.
I'll come up. Okay.
Sorry, I don't mean to insert myself. I just want to help you.
No. I think it's really important. So I am a LEND fellow, and as part of the LEND program, I did it in New York through New York Medical College. And you have to be in the healthcare field, or I did it because I'm in education. And as part of that program, one of the hallmarks of the program is that because they're all associated with university centers of excellence, and there's, I think, 46 of them now across the country. And one of the purposes as a LEND fellow, and I was a family specialist, so I came in as an educator, but as a family specialist, because I'm living the life of supporting somebody who has special health care needs. And so one of the things that I had to do was go into the local medical colleges, the medical schools, and meet with medical students and really try to explain to them that when they come in and they see a patient as a physician, that it's a kid, it's a family, there's a story behind that family. And you try to impress upon them the need to just have empathy, because we've all had doctors who don't have empathy, and they're very quick, and they want to just tell you whatever they want to tell you, and they want to walk out the door, and and see their next patient. And so it is, I guess what I'm trying to say is that there's more and more doctors who understand this, whether or not they're practicing it.
Yeah.
And so I think that you shouldn't feel uncomfortable. And I know culturally a lot of people do feel uncomfortable, and that just comes from who we are and how we grew up, and not necessarily wanting to, buck people who we consider to be, more knowledgeable than us on a certain subject. But the truth of the matter is that, like Allison and Amy said, if you if you're uncomfortable with your doctor, you have the right to change doctors, and you have the right to push your doctor. And if your doctor doesn't want to answer your questions, then find another doctor. But they may not want to give you the time, but many of them probably really respect you when you ask those questions, I would think.
I was just going to say I have some phrasing for that. So my name's Lindley Moore. I'm a speech language pathologist at the Kenny Krieger Institute. Y'all are a crying group, and so am I. So,
Lindley, can you hold the mic closer?
yes, so sorry. That's what you were doing. Thank you for that communication. I also travel the United States and soon the world surveying hospitals for rehabilitation. And so I also have a daughter who was just recently diagnosed with POTS. So that condition is, that's a different conference. But, and I have parents that are in healthcare issues. So the phrasing I would recommend to you is, this is an unacceptable standard of care. I find this to be an unacceptable standard of care. Use that phrase. Clinicians and doctors know what that means. And for some reason it works. It's worked for my parents, it's worked for my daughter. The other thing is, I will say, or I will recommend people say, I'm not feeling heard. Just say that and pause. That will take anyone who's in the moment of, oftentimes I find clinicians and doctors, when they don't know the answer and they don't know what to do, that frustrates them too. But some people react in a dismissive way, and then some people open up more. And if you don't get someone who opens up more, change.
I do think it's going to change, that we are going to see more and more doctors that are more empathetic. I know that UCLA, pre-pandemic, I don't know if they've started the program back, but all of their residents or their graduating med students, so who are about to be residents, participated in this program where they went to people's homes who had medically complex family members. And so every year, pre-pandemic, for several years, we had 5 med students that would come over to our house and just spend time with us, because that's humanizing disabilities and various medical conditions for them. So I think it will change, but I think we can all understand what it's like to have so many demands that you're only afforded 15 minutes with each person, and you just want to get to the next person. I can relate to that in my own work, but I think as soon as you are asking and saying I don't feel heard, or asking more questions and doing so in a way that it's almost like most people then couldn't help but help you.
I also think it's helpful. I've started asking for longer appointments. So when I book, I say, I have a medically complex child, and I would like a longer appointment because I know that we will run over. And so that respects the doctor's time. So we're not and respects, their future patients, that I'm not ruining their whole day, but gives me the time that I know we're going to need with the doctors. And I've never actually had a doctor say no. So that's helpful. I also think that my favorite doctors, the doctors that we currently have, all of them at some point have said to me, I don't know the answer, but I'm I don't know. And I want a doctor who does not think that they know everything. And so they will say, let's figure this out together. Do you have connections? Let me ask these people. And that's that's the mindset you need when working with rare diseases.
When we looked for a new neurologist, because ours left Los Angeles, when we looked for a new neurologist, I said, I don't need them to be a specialist in movement disorders. I don't need them to be a specialist in CACNA1A, because that's not going to exist. In LA, it doesn't, even though we're in one of the biggest cities in the country. I said, I just need them to be humble enough to listen to others. And so when I say I'd like you to have a conversation with Dr. Helbig at CHOP or Dr. Gomez in Chicago, I need someone who's humble enough to think that Dr. Gomez or Dr. Helbig might actually know something that they don't. And in my first time we sat down with the new neurologist, I said that because he said I don't know CACNA1A, and I said I don't need you to. I need you to be willing to learn and to collaborate.
I think that's the most important statement you just said. If you have a caregiver or a practitioner who can say, I don't know, I think that's the most important thing. I teach all of my employees that. And then secondly, you're the expert on your child in this very rare disease. You are the most important person in this team. And if somebody you're working with doesn't feel that way, that's not who you want to work with.
I also think that as Emma has gotten older, we've taught her how to advocate, because I do find that doctors they want, yes, you have a lot of information, and some of our kids aren't able to communicate and advocate for themselves. But those that are, it is powerful when Emma is the one telling them, like, this doesn't feel right, or this medicine makes me feel this way, or I feel sick when this happens. And I always find that they're more willing to listen to her in some ways than they are to me, because they think that I'm filtering it in some way or presenting. And so that's really helpful as your child gets older, if they're able to help them to advocate for themselves.
Yeah, we were actually supposed to have a neurologist who specializes in the transition to adult healthcare come and speak this weekend, and unfortunately she wasn't able to make it. So that's something that hopefully we'll be able to do the next time, because it's really, really important. My daughter's 27, and she's an adult, and doctors won't speak to me. They only speak to her, and the ones that obviously we know speak to me, but otherwise we walk into a doctor's appointment and they look at her and they ask her the questions, not me. So your child, it's really important if they're able to do that, to teach them how to do that. The other thing I wanted to say is that, and I can't speak to this because Emily's never had a hemiplegic migraine. However, we do have resources on the website about hemiplegic migraines and care plans and what to do if you end up in the emergency room. And I understand that if you have a hemiplegic migraine as an emergency room, they have to rule out the worst things first. And we have doctors in the room who can, talk to this, and so that might be a stroke. But there's no harm in also giving the rescue medication that is recommended for a hemiplegic migraine at the same time. And so being able to bring that resource with you to the emergency room and have it printed, and I know there's people in this room that have that resource printed and it's in their go bag, but to have that at the ready, or have your doctor make some sort of an emergency plan that you can, no matter where you are, bring, so that if nothing else, it's not just you talking, but there's the stamp of another doctor, or there's the stamp of the CACNUNA Foundation. And we do have doctors who are willing to speak to any, doctor around the world, really. And they have done that for us. Dr. Helbig at CHOP and Lena Lusk, who is his genetic counselor, they will get on the phone with any doctor. They have committed to do that and help with player care plans. So just know that that's a resource that we provide. And if anyone wants to speak to that and having had used it, Kendra, yeah.
Here, wait, there's a question.
And Karen, I think, wanted to say something.
I was just
We'll
gonna
get
go
you a
back.
mic.
Yeah. I was just going to go back to I have a 16-year-old who's going to be aging into adulthood, and it's kind of like the whole team. I feel like I have to come out of pediatrics. If you, Lisa, having gone through that, would talk about your journey for a moment about it.
Since I brought up the hemiplegic, do you want to just talk to that first, and then I'll circle back?
Yeah, so I feel like maybe I'm the queen of subpar medical intervention. I've experienced it twofold in the sense that my son, most of you know, is adopted through foster care. So not only did we get a lot of pushback in the sense of getting medical providers on board, but we had pushback from biological family early on. We had pushback from DCS or DCF or whatever your state calls it, pushback from their medical board locally, just trying to intervene and get involved. For us, it took 6 years to get to diagnosis. And my son is 12 now. And even to this day, we still continue to have subpar medical treatment. And to this day, I come in flags barren. I don't know how to explain it. It's just, I push, I get feedback from nursing staff or other providers that say, you are advocating better than anyone we had walk in our hospital. You know that this problem exists within our unit, our neuro unit has this particular downfall. Call the patient advocacy line within the hospital and advocate for not only your child, but for all the other kids with rare disease. It's for us, it's like we're on a neuro unit and you're telling me you don't have a neuro that can come in on call in the middle of the night when a child is having a severe issue. That's a huge problem. You pick up the phone, you call the patient advocacy line, you get somebody involved, you get a lawyer, a medical advocacy lawyer involved. Just use the words. Even if you don't have the funding to get the lawyers involved, just use the words. Sometimes the threat is just enough to get the doctors and the staff and the nursing, like the charge unit nursing, on board and willing, and you will see a drastic change in just the demeanor of the providers and the team that flows in to get what your child needs. And it might not look pretty, it might not be the way you wanted to present yourself in a moment of stress, but on the backside of a bunch of experiences, I know it's what I had to do for my child and for other children. And as a physical therapist, and just constantly advocating for other kids with special needs and do this, do that, having those empathetic conversations with other families who are in that diagnostic journey is critical. Just having connections is critical. But use your words. Use your words and stand up for yourself and advocate. Even in the journey that we're on, we can get what we need from providers who are willing to say, okay, I don't know, but I'm willing to reach out. I'm willing to try your suggestions. I just think just bouncing off what Amy has said, it's a hard journey. It's not easy, but always pick up the phone and advocate for your child, or ask for the charge nurse, or ask for who's in charge. A lot of people, a lot of the nursing staff are kind and generous. They want to help. They just don't know how.
I was going to say, in a hospital setting, I think nurses are your best friend. Like, asking for the charge nurse, they have been the biggest advocates, and we have had awful experiences in hospital settings. Sometimes they're just completely dismissive. Sometimes they tell you it's like psychiatric, and you're like, no, like you don't understand. But the nurses have been helpful.
We have another question. I think Lindley was, and then we have to go back to Lisa. But Lindley, you wanted to point.
Say those three phrases I would use. Your first one, I kind of start at one and escalate up. The first one is, I'm not feeling heard. That gives them an opportunity to, come back to being human and empathetic. You're cueing them, right? We all should be heard. The second is, this is an unacceptable standard of care. That goes to the next level. That will often get you a charge nurse. That will often get you the next person in charge, because you just used a medical term that we use on that side. When somebody says standard of care, that's what CARF and JACO, those are part of our regulations. And the third thing is, if you ask for a patient advocate, every hospital has it, and they have to respond and come up with a plan and answer within 24 hours. Now, I would not go in and use that first, right? But that is your ace in the hole. If you have to go there, you'll know when you have to go there and use it. So those are my three recommendations. I'm not feeling heard. This is an unacceptable standard of care. And now I need to speak to a patient advocate.
So we're going to circle back to Karen's question to Lisa.
Sure. So most pediatricians, and I think Deb's still here, most pediatricians, I believe, will see your child until they're about 22 or 23. At least mine would. And at that point, we had to transfer out to an internist, to adult medical care. We had 4 internists before I finally found one that we're now using as our regular internist. And it's interesting because I went into each one with a packet of information. They obviously had the medical records from my pediatrician. And I said, I really want to tell you a little bit about my daughter. And the first 2 dismissed me. You could see their eyes were glazing over. They didn't really care very much about, what it meant to have a CACNA1A diagnosis. And so each time we left, and I never actually went back to that doctor, and then we went to another practice. And anyway, the third doctor, Emily, had bronchitis, and she gets bronchitis every single winter, and if she doesn't get it treated right away, like most of our kids, if she's sick, she'll have a seizure. And so it will lower her seizure threshold. And so I called the internist, and I said, my daughter, I think, has bronchitis. I need to bring her in. And they said, oh, we have an appointment next week. And I said, no, that's not going to work for us. And then I realized how much I missed the pediatrician when you could do walk-in hours, and I didn't really want to walk into an urgent health clinic. I mean, I could have gone, and that's what we ended up doing. And you go into urgent care, and they'll see you and they give you an antibiotic. But so then I found another internist, and that internist has been wonderful. But it's a process. And I think in retrospect, I should have relied more on my pediatrician to help me with that process, and I didn't. And he didn't offer. But I think that is really important to say to the pediatrician, I need your help with this. And there's nothing wrong, I don't think, with setting up a meeting with your pediatrician and the internist, or maybe just like when you have a new baby and you might interview a couple of pediatricians, interview some internists, and then set up a meeting with that internist and your pediatrician to really go over your child's, medical records and the care that they need. And then as far as like neurology, really the same thing. I'm lucky because we're in a large neurological center where the transition of care is sort of seamless because there's pediatric neurologists and adult neurologists in the same practice. But if you don't have that, that would be my suggestion. But it's not easy. And then we're going to have the special education, breakouts, and let's not even get into post-secondary schooling. So this is like a whole nother, sometimes they say little kids, little problems. They're never little, but it's a whole nother world when you're talking about adult care. So I'm happy to, talk more about this. And I do think that this is something that maybe we do a webinar on, but we have to really do a deeper dive into this. So thank you.
Yeah, go ahead.
Hey, so I'm sorry, I'm losing my voice today. My name is Michelle, and I'm actually not a CACNA parent, but Chrissy is, and her and I have been friends for almost 10 years now. I met them on a camping trip. Her son is 16. What kind of makes our situation is a little unique is I'm actually an emergency medicine provider. So a lot of the times when her son has severe hemiplegic migraines. So one of the things that I just wanted to speak to was that to-go bag is like a huge thing. I personally love when patients come into the ER who are medically complex, rare disorders, and the parents hand me a packet or a sheet of paper. Hey, this is the diagnosis, this is the treatment, here's all of our physicians, here's all of our meds. Because for me to go to a database and try to look up and learn what you guys have learned in years is very challenging. Sometimes maybe I just came from a code or I just came from another complex patient. And we, on my end, I can't speak to the whole medical community, we want to do our best to give each of our patients in the ER the best outcome. So I remember one time we actually walked in and our head of the ER, like our medical director, was going to be taking care of Nicholas. And I said, John, I just need you to trust me. I handed him the information and his treatment was started right away. We talked about, hey, do you want to be admitted? In a hospital setting, especially an emergency room, we do a lot now of what we call shared decision-making, where I will look at the parents and I will say, hey, do you feel comfortable taking your child home? Are you back to baseline? I see adults and children. I've been doing this almost 10 years now, and I'll say, hey, do you feel comfortable taking your child home? Do you think they need more? I will call the specialist. I will have a conversation. I will get the recommendations from a specialist. So I think from the opposite end of it and kind of being in this situation where, yes, the pediatric intensivist wanted to send Nicholas home with a feeding tube, and I was like, nope, hands down, we are not. And I said to her, we're not doing that. So even someone who in medicine sometimes has to kind of push back a little bit. At speaking to maybe living in small towns, if your child is admitted to a pediatric floor, depending on what the services are, kind of an inside thing, you can request transfer to a higher level of care facility. We are at a level 1 trauma center, but we do not have peds neurology. We do not have peds cardiology. So we can try to request to be transferred to where all of Nicholas's specialists are, but we need an accepting physician at that hospital. But you can advocate for that. So if you ever feel like you're not getting the quality of care that you need, you can always talk to them and say, hey, we'd like to be brought to a higher level of care facility. And you can request that. Is it always going to be met? Are you going to have an accepting physician? Maybe or maybe not. But just from kind of being in both sides of the situation as an advocate, as a caregiver, and then also being on the other side, seeing these patients come in, you know, and I say to my parents too, like, you are everything that you've learned, collected. I trust your opinion on your child, what you think is their baseline, what is not. So I agree, just keep advocating for your kids. Have that plan, be firm about it. And most providers are more than likely happy to call a specialist, to call someone else, because I don't know. I don't know how to, I do. But, you know, there are other things. We have a lot of sickle cell patients, and they come in and they're like, here's the plan, antibiotics right away, control this, and maybe we need to transfer. And it gives gives our patients the best outcome. It gives our children the best outcome. And so I'm here if anyone has any like hospital type questions. Having done emergency medicine for almost 10 years, I'm happy to speak to anyone.
This is exactly what we wanted to happen in this session. That's amazing. Thank you.
Well, if I can just follow that up. So in 2020, right when COVID was happening, I was talking to Dr. Gomez literally via email. I had never met him. And we couldn't get out of state approved. And he said, Chrissy, I'm going to just call you. And I was like, wow, this is so great. So he called me, we're talking. And I was like, I know it's going to happen again soon. I know it. Well, within a week, Nicholas had a hemiplegic migraine, and I emailed him, and I was like, I told you it was going to happen. I knew it. I'm sitting on the floor waiting for an MRI, and I had told the doctors it's not really PICU, it's critical care, and they said, oh, well, you're talking to someone? We can't do anything until we talk to him. And I was like, oh my God, but he's never seen Nicholas. Like, now what am I going to do? But I reached out, and they got to him, and they got his cell phone number, and then we had a plan, but that was before I had the paper. 2 years later, we went back, I had the paper, and now I was good. So it was a complete difference. We wasted like days because they weren't really sure what to do. And those days, he's, you know, coma-like anyway, but still, it was days. So it really does, you need that piece of paper, you need the contact for sure.
Thank you. I think, was there another?
I just wanted to like piggyback off of emergency room. My son's 3, and he's had 3 hemiplegic migraines. The last one was so severe that he was intubated for 4.5 days, and we had a 12-day hospital stay. But something that really helps me, also a nurse, so I'm very comfortable in this setting, and it's a very oddly calm, and so a lot of times when I get to the ED, I tell them exactly what I need, and I'll have PD neurology paged like very early. And then often I'll just ask for the attending. So the nurse will be in the room, the resident and the attending. And I just kind of go over the action plan of what he needs. And then I also get like all his orders put in early. So everything is like readily available. So if anyone needs any tips or you can reach out to me, or I'm here. But I'm like, I don't know, it just seems what I've been doing has worked. Sometimes I do have to kick and shout respectfully a couple times, but just having the plan. The first time I didn't even have my action plan, and Sunitha and Lisa were coaching me through what to do, but they always want to say it's a stroke, and so I'm always very firm saying, this is a hemiplegic migraine. The very first admission, I was like shouting for the Diamox. I didn't have it, but now I have my plan, I have my rescue meds. So I think that's another thing, is just almost having that action plan in case is always good, because I didn't have it the first time. So that's just my idea, is really helpful. But
One thing, oh, sorry, go ahead.
I just think like, I start off calm and nice and sweet, and I'm like, hey, let's just get everybody in the room, because this is a long story, and this is rare, and CAC no 1A, and they've been receptive to that. So we start off, everyone's there. I don't know, it started me off on a good foot most times in the emergency room.
I always think sometimes people might feel like you're being rude or mean if you say, I want the attending in here, and like it's insulting, right? And so that's the perfect way to do it. Is this is complicated? Can we just get everybody in here? I've also, when we've had emergency room visits, I have said, I like to the resident, I am sure you're right. I trust you on this. I would feel really good if we can also just talk with you and the attending together, and trying to just approach it that way. It has helped me, and it really has been through family members in medicine that have told me sort of how to advocate for that. But I like the idea that you say of sort of just like, this is complicated, can we all get together?
I love that.
And getting the orders in early, too.
I just want to do a quick plug for my 2:30 group. I've got if you want to hear more about advocacy, Tracy Wright, you can read about her in the program. She is well-versed with advocacy issues. And so as our champions get closer to leaving school, I've asked her to speak about it. So she's got some slides about it. So if you want another dose of advocacy, come see me and come see our group.
So I'll just say to that, and when we have that breakout, we have 2 breakouts. So one is on special education advocacy, and one is focused more on that transition of care and towards the post-secondary and adult advocacy and vocational rehab. So if you have a child that's on the, you know, I know you're right in the middle, but so you'll have to, maybe you can pop back and forth.
They're all
between both
being
rooms.
recorded, and you guys will all have access to the recordings from both days. So don't feel like you're going to miss content. It'll be available after the conference. Deb.
Yeah, just real quick, adding on to so for epilepsy, it's also helpful to have a paper form. I thought, because I was a doctor, I could walk in the room and be like, so I'm a pediatrician, like this is what my daughter needs, and time after time after time, they did not care. They didn't care until I had a paper that I could hand them that was signed by her neurologist. So I'm just echoing what y'all said. And then I'm sorry, I had stepped out of the room. I think someone was asking about transition to care and at what age you do that. So every single office is different. So whoever is seeing your child now, you should just ask them, at what age do you stop seeing patients? A lot of times it's 18. My practice is 21. It generally does not go past 21. In the past, and if you have an older pediatrician, they will see children with rare diseases or special needs past 21, maybe 26, maybe 30, but that's kind of going out of style. And then when you go to transition, there's basically three main places you go. So after 18, you either go see a med peds, or you see family practice, or you see internal medicine. So I'll just say real briefly what those are. So med peds is somebody who has specialized, I believe it's 2 years in pediatrics and 2 years in internal medicine. So they're kind of like a pediatrician and internal medicine doctor all in one. They're usually really kind of nerdy, and that might be a great person to find. Then family practice, I think it just depends. A lot of times family practice is seeing from newborn all the way through elderly, so you just have to find the right fit. It could be, like I'm a general pediatrician who loves special needs kids, so if you found a family practice doctor that has a personal reason, either their own child or other kids they've taken care of, they could be a good fit. And then when you transition to them, you know, you might even want to transition at 16, and then they can just be with you while you already have your specialist, and then your pediatric specialist, and they can help get to know your child, and then transition to adult specialist. And then the last type of doctor would be internal medicine. So they generally do not see patients under 18, right, Nick? Yeah, are not approved under 18. And so you would transition to internal medicine after 18, and they would really have no background in kids, but they could be an incredible doctor for rare disease. Does that answer the question that I missed? Yeah, okay. Oh, Nick.
Just for people who are preparing for that transition, just know that it will be shocking. I do adult medicine, and I see kids transition from specialty pediatric services into the adult care. And adult doctors are not pediatricians. They have a different mindset generally, a different approach, and it can be a little bit jarring when you've had a pediatric team around your kid and you go to the adult system. So just know that will be it will not be a smooth transition generally, just to prepare you.
We have time for one more question or comment. Story, tip over there.
So as I'm listening to all of this is such great information. We have been very blessed with a team, medical therapies and otherwise, who have been really receptive to Louise's condition. And even in those moments, it can feel unsettling. I don't remember all the terminology. I don't remember which specialist came from which place. And so what I actually do is I carry around this book in a little binder if it's from the conference. And so in those moments where the doctor might ask, well, what did you learn? Or can you speak a little more to this symptom? I say, well, Dr. Grossman at NYU can tell you a little bit more about eye movement disorders or things like that. And so my tip or trick, if all of this feels overwhelming, you feel like you can't remember all of this, I just took my CACNA 1A conference booklet around from 2022 to all of her doctor's appointments, and then was able to open up and say, well, and so actually our neurologist is in contact with Lena Lusk. Our PD ophthalmologist has read some of Dr. Grossman's work, I believe, and then we're also able to speak to the research that's happening, because it's a lot of information that's so encouraging, and we can't always remember it. And so that has been the easiest little thing that I can do, is just carry this around to doctor's appointments.
Thank you for sharing. Allison, are there any online questions?
I think most of the online questions have already been answered, so I'm just going to get email addresses and they will follow up.
Okay, thank you. And Lisa, you were going to say something else.
Well, this has nothing to do with this conversation. But when I've been sitting and I've been monitoring the emails that come in also, and Allison's been monitoring, and Amy have been monitoring the virtual. And just before I got up here, there was an email that said, I'm from France, and my daughter has such and such a variant, and I was told by the person moderating the conversation that you all might know someone else with that variant. Well, the answer is it's my daughter. So we have another D1634N, Emily, and maybe instead of Italy, we're going to go to France on vacation. But anyway, but I just want to tell you that that's the power of this, one of the powers of this foundation. So bonjour.
So we were panicking a little bit yesterday when we heard Linda couldn't make it to this session, but we also realized in trying to pivot that there was so much knowledge and experience in this room, and we really wanted you all to share, and I think we accomplished that. So thanks for helping us pivot and sharing all of this.